It is my honor today to be able to introduce to you Ron Honberg, who serves as the National Director for Policy and Legal Affairs at NAMI, which for those of you who don't know it is the National Alliance on Mental Illness. As Director of NAMI's policy team, he oversees their work on federal and state policy issues and on legal issues. And in recent years, he has worked particularly on issues affecting people with mental illness, involved with criminal justice systems, including jail diversion, correctional treatment, and community reentry. And Ron was also one of the lead authors in NAMI's 2006 and 2008 Grading the State's Reports. And so hopefully we didn't do as poorly as we tend to do on other reports that come out about the state of Missouri. So,
trying to remember.
Oh, okay. Oh, a D and a C.
Actually, the C was above the national average, believe it or not.
Oh, well, that's actually good news then.
Were often tough.
So without any further ado, I'll go ahead and introduce Mr. Honberg.
Thank you. We were sitting like the rest of you listening to, the last speaker, listening to how adeptly he answered all the questions and how fluent he is. And I have to say, I read The Social Animal, David Brooks. It's a wonderful read, and there's some copies outside for those of you who it's too bad he's not here to sign an autograph. So we were sitting there with our mouths hanging over, listening to how fluent he was. And at one point, Veronica Manahan, who's a lawyer here in town, and actually way back when was an intern at NAMI with me, turned to me and she said, I really feel sorry for you. Because not only is this app now, David Brooks says, maybe I have to rethink this. He said that this after lunchtime slot is actually a good one, that you're full and you're happy. When usually after lunch, I'm kind of sleepy. And my experience with, speaking during that slot is that you really have to be on top of your game to keep people awake. But maybe I'm wrong on that. So not only do I have that after lunch slot, but have to follow somebody like David Brooks. That was really incredible. But I am here to talk about a topic that I'm very, very passionate about, mental health and mental illness. It's one that I've been involved with not only through family experiences, but some personal experiences, but also in a professional context for 35 years. Probably close to 40 years now that I think about it. For about 15 years as a service provider and in a social work context, and for the last 22, 23 years with NAMI as an advocate and as a lawyer. And I'm really very, very pleased that it's part of this program, and that Karen had the vision to include mental health as the second topic of the conference today. And I think it's very timely because, with these changes that are taking place in this country, we've had a lot of discussion today about whether they're good, whether they're bad, that there's, is it the best of worlds? Is it the worst of worlds? Is the glass half empty? Is the glass half full? Certainly the healthcare system in this country is changing, and I think we do have some opportunities in the mental health world to address some of the problems that we've historically really struggled with, and particularly the reality that the mental health system has always been a very different system. It's always been way, way, way outside the mainstream health system, and maybe we have a chance now to really integrate mental health in a meaningful way into the overall healthcare system, with all its problems, certainly, but with all the opportunities that entails, and start to view the brain as part of the body, basically, as opposed to having a second class, wholly separate public mental health system that really doesn't interface very well with the rest of the public health system. So let me start, actually. I'm going to start on a little bit of a negative, well, not a negative, a little bit of a downer note, and that is by describing to you, where the mental health system is today, and then hopefully I'll end with on a little bit of a happier, more optimistic note, talk about some of the opportunities that we have. And I want to start by reading you a little story because David Brooks said, you know, if you can put it in narrative form, it's always much more effective, and I agree with him on that. But it's actually an email I got literally as I was leaving the office yesterday morning to catch a flight to come here. And I read it, and I thought, it's so typical of the hundreds, if not thousands, of emails I've gotten over the years like this that I just felt like I had to read it. And so I'm going to read it very quickly. I'm not going to give you the name of the person, but it's from a woman who lives in Milwaukee. And, you know, she says, you know, I found your contact information on the NAMI website. I'm writing to you in hopes that you can help me. My mother has schizoaffective disorder and recently decided to take herself off all her medications. Fairly common scenario, right? She's also diabetic and insulin dependent and in her 70s. She has a long history of mental illness, has been hospitalized a number of times due to relapses in her illness, and has done a number of extremely dangerous things that include walking down the middle of traffic in her nightgown, waiting at the top of the stairs with a loaded shotgun because she thought my father was going to come and kill her, threatening my aunt with a knife, and tying herself naked to a tree in Center City, Milwaukee. I'm at the end of my rope. I feel as if every resource that is supposed to be in place to help people in situations like these have presented me with no help at all. My mother lives in Milwaukee. I live 30 minutes away from here. I have a small child to care for. I have a job, and I also take care of my elderly father who is legally blind. Certainly gotten lots of emails like this and letters and calls, particularly from women who are, you know, dealing with challenges at all ends of the spectrum. It's frequently the women who take on these burdens, sometimes the men, but more often the women, as I think many of you in this room probably know. My mother is being released from a psychiatric unit she is in today. I will not be able to continue on this journey of trying to help her. At this point, I'm exhausted. I need to consider what's best for my immediate family and the protection of my daughter. I grew up with the insanity that has been going on these past weeks, and I won't expose my daughter to it. Something is very wrong with the world we live in, where someone can be in such extreme danger to themselves or to others, and due to budget cutbacks, greed, ignorance, apathy, lack of compassion, etc., no one is willing to help. Something needs to be done to bring needed change. And, you know, again, if it was, and for those of you who are in the mental health field, you know that this is not an unusual occurrence at all. And then she attached to it about a 15-page journal of the last 3 weeks. And the scenario is basically that her mother's being discharged from the hospital, probably in no better shape than she was in before, still believes there's nothing wrong with her, so she's not going to take her medication, you know, and is going right back into the situation that she was in about a week ago, and no real coordination with follow-up care. And of course, it's very difficult when somebody doesn't think they're sick or need help at that particular point in time. And so this, you know, email of desperation. And again, sorry to start off on a downer note, but that's sort of the reality of the public mental health system in many parts of the country today, particularly for people who don't have a lot of financial resources. So, you know, we start off with the premise. This is, again, to those of you, I've been listening to you all day. It's been a fascinating day, and there's some fascinating people in this room who I've learned a lot from. So, you know, I'm sure I don't need to do much to convince you that every child and adult who experiences mental illness deserves the opportunity for recovery. And there are some people, many people who actually do recover. I don't know if you've been following some of the inspiring stories that we've seen in recent weeks in the New York Times. A reporter decided that, you know, he had done a lot of stories over the years about really bad things that happen to people with mental illnesses, and he decided he wanted to portray some really inspiring people. So, you know, he wrote his first piece was about Marsha Linehan, who's sort of the mother of a psychiatrist, or I don't know if she's a psychiatrist or a psychologist, but she's the mother of dialectic behavioral therapy, a very revolutionary treatment initially in the treatment of borderline personality disorder, but is used for other disorders as well. She came out, she wrote in this New York Times piece, she came out basically of the closet and said that she had been diagnosed with borderline personality disorder as a teenager and had numerous suicide attempts, and you know, she had gone through hell for years and years and somehow got herself through, you know, graduate school, and, you know, again, became one of the leaders in the field through just incredible fortitude and hard work and good treatment. She linked herself up with good treatment and a good support system. Many other pieces. Last Sunday's piece was about Karis Myrick, who is actually the first vice president of the NAMI National Board right now. An African-American woman from Los Angeles who has schizophrenia, who is on the verge of earning her PhD, is running a very large peer provider program in Los Angeles, the largest in the city. Her life started to turn around when she took on the challenge of running what is in effect in many respects a large corporation, and has done it exceedingly well, and is, as I said, quite brilliant, but also experiences with struggles with significant symptoms. In fact, about 6 months ago, she was on the verge of hospitalization, and she checked herself into a very expensive hotel in Los Angeles and felt like, I need to pamper myself at least for a day before I go into the hospital. And she called and she texted her psychiatrist at 12 midnight and basically told him that she was struggling with feelings of suicidality, and she needed to communicate with him, but she was determined she was going to stay in this hotel that night. And he texted her back at 12 midnight on the Saturday. And, I thought, wow, how many... You probably do it, but how many psychiatrists, have that kind of relationship with their patients and provide that level of support? That's not particularly typical. So again, my point, I didn't even mean to digress here. You'll find I digress quite a bit. It's just part of my nature. But my point is, if you can, in fact, get to a point where you have the resources around you and the supports around you, and you have a level of self-awareness and understanding of your illness, take control over your illness, you can do very well, just like you can with diabetes and cancer and heart disease and the other illnesses that affect Americans. I mean, a key to recovery, obviously, is understanding what you need to do to stay well and take the steps to stay well. Here we have Glenn Close and her sister Jessie. Glenn Close and Jessie have been doing a national campaign to raise awareness about mental illness and reduce stigma. And Jessie is, well, most of you know what Glenn Close, what she looks like, so you can tell who Jessie is in the picture. I've heard her speak to groups of 5,000 people. She's an amazing speaker and an inspiring speaker. She's inspired a lot of people to get on that road to recovery. But this is a more common image of mental illness, right? The person in the street. And yet, even for that person, treatment works and recovery is possible. They get the right kind of services they need. I know it's hard for the average American to feel that when they stumble over the person. Most people don't get the mental health care they need. The studies suggest that fewer than 50% of all people with schizophrenia, for example, have access to even minimally adequate treatment. And so, the status quo in the country at this point, in most parts of the country, this is crisis response for people living with mental illnesses. Our law enforcement officers are on the front line. I mean, again, families will tell you that oftentimes when their loved ones are in crisis, they're basically told, call the police. And sometimes that can be not such a good idea, especially if the police aren't well trained on how to respond compassionately. I'll tell you that I've done a lot of work over the years with the police, and there are police departments in many cities in this country who have really invested in training their officers on how to respond compassionately to people with mental illnesses in crisis and how to de-escalate the crisis. And these are called CIT, Crisis Intervention Team programs. There's one in St. Louis that's really great, and there's one in Kansas City and Lee's Summit and some of the surrounding jurisdictions that are really great. And you have on those teams, designated police officers who may be better than just about anybody in responding to people in psychiatric crisis. But still, that's the exception rather than the rule. If a person is having paranoid delusions about the FBI being after them, and authoritarian police officers in blue uniforms show up and speak in aggressive voices and move in on the person and surround the person, it can be a prescription for disaster. But they're the crisis responders. Our jails are, in many cities, the de facto psychiatric treatment facilities. Just about 4 months ago, Sheriff Dart of Cook County in Chicago actually was quoted in the Chicago Tribune as threatening to sue the state because he just was sick of the state turning to his facility to be a psychiatric inpatient treatment facility. you know, the amount of money that they were spending on treating people, on providing people with medications. Once somebody is arrested and incarcerated, they lose their Medicaid, and you know, the jails and prisons bear 100% responsibility for the you know, often prohibitive costs of medications. And unlike the mental health system in the community, jails and prisons have a minimal constitutional obligation to treat people. There's a body of case law that says that prisoners with severe illnesses have a constitutionally protected right to treatment. So, so I guess the numbers are anywhere between 16 to 20% of all inmates in jails and prisons in this country have severe mental illnesses. With the budget crisis that has occurred in recent years, we're eliminating hospital beds en masse, both public and private. About the National Association that represents the state mental health program directors estimates about 4,000 beds have been eliminated in the last 2-3 years. A lot of private hospitals have gotten out of the psychiatric treatment business. Med-surg beds are more lucrative. And you know, eliminating beds and emphasizing more of a community-based approach to treatment may actually not be a bad idea. It can work, but only if you're actually investing more resources in community-based treatment. But what we've been doing nationally, and again, I'm not trying to insult anybody in this room. I'm not talking specifically about Missouri right now, but nationally, what we've done is we've reduced our investment in both inpatient and community care. And again, homelessness, I don't need to tell you about, you know about that. One of the it's interesting, there's been such a focus in the mental health world historically on keeping people safe and keeping people out of hospitals and, you know, and keeping people alive, that I think we've sort of been remiss in thinking about individuals with mental illnesses as whole people, as people who have a right to good health generally. And I know when I started out in this field, we commonly used cigarettes as a reinforcer, particularly in hospitals, for good behavior. People would get cigarettes. I know that things like extreme weight gain weren't paid much attention to. And oftentimes, people complaining of symptoms, you know, it was just assumed that was a reflection of their psychiatric symptomatology. A guy I worked with at NAMI, his brother died in a state hospital in Iowa after having complained for, you know, months of stomach pains. Finally collapsed one day, and they discovered his body was riddled with cancer. Now, who knows if they could have saved him, but the fact is they were ignoring his symptoms. I'm sorry. I know you guys are looking pretty down at this point. I'm feeling pretty down too, but I have to say that has started to change in our field, and I actually give Joe Parks, who I don't think Joe is here today, credit as being one of the real pioneers in getting both the general health care sector and the mental health care sector to start thinking about some very, very disturbing statistics. Like, for example, people living with serious mental illnesses dying on average 25 years younger than the rest of the population. The average life expectancy of an adult male with schizophrenia in this country is less than the average life expectancy of a quote-unquote normal adult. That's probably not the right term to use, in Bangladesh, where obviously the early death rates are very high. And, you know, you see the contributing factors that I list. And smoking is right near the top of the list. Ken Duckworth, who's our medical director, says, you know, if we could really make a dent in cutting smoking cessation among this population, that would have a very, very positive impact in reducing the differential death rates and the presence of so many comorbid illnesses, heart disease, hypertension, diabetes, etc. You know, I have to say that the side effects of medications have been a contributing factor too, particularly the newer generation, the second generation atypical antipsychotics, which for many people are life-saving and work really well, but also have potentially very powerful metabolic side effects, and which weren't really discovered until about 4 or 5 years, or acknowledged or discovered until about 4 or 5 years after some of the medications were approved. So psychiatrists treating those individuals started to see that their patients were gaining alarming amounts of weight, that their blood pressures were shooting through the roof, that they were developing symptoms of cardiovascular disease. And it did come out that, yes, these are side effects for some people. Everybody has a different metabolic composition. You can tell I'm not a doctor in the way I talk about these things. But so these metabolic side effects don't impact everybody, but they do a significant number of people. So we are seeing more and more psychiatrists, psychiatric nurses, other mental health professionals starting to focus attention on talking to people about eating good food, exercising, doing things they can do to control their weights when they're taking these medications. We're seeing a growing focus on smoking cessation, and I have to say NAMI, my organization, was pretty slow to the gate on that one. We started to see some states actually enacting smoking bans in state psychiatric hospitals, and I'm sometimes our media spokesperson, and I was our media spokesperson on that, and I remember once I got Joe Parks quite pissed off at me because we were both on an NPR story, and I said, that's a really bad idea. Not that people shouldn't be helped to stop smoking, they should, but to ban people from smoking when they're in the throes of a psychiatric crisis is a prescription for disaster. Hasn't turned out to be, interestingly enough. And I think we're all rethinking our position on that. And again, another example of Joe in Missouri being a pioneer in a positive way. So I've said this 3 times now, so I think that point has been made. And again, I suspect a point that I don't really have to argue with you about. So again, what are the facts? How have we gotten here? Why is it that things have gotten so bad? Now, I don't want to be disingenuous. I have to say, even during times of relative economic prosperity, our public mental health system in this country has struggled. And I don't think that the problems are all due just to money. I think that they're also due to some of the themes that we've heard all day today about fragmented systems, about poor data, about poor coordination, about misalignment of incentives and things like that. That's been true in the mental health field as well. But I think more than anything else, it's because so-called mental patients in this country have been treated like second-class citizens. I keep digressing and telling stories, but this is an image that is sort of indelibly etched in my mind. A few years ago, I have this habit sometimes of working too hard. I suspect I share that with many of you in this room. And so this was a summer evening at the NAMI office, and it was about 8:30, 9 o'clock, and they turned the air conditioning off, and I was sitting there, and I was really stressing out about all these emails I hadn't responded to, all these calls I hadn't returned, all these reports I was, with imminent deadlines, and I was working. I was sort of in one of those bad spirals where I probably wasn't making good decisions. I probably should have gotten up and gotten something to eat. And all of a sudden, I started to feel really dizzy. And I did, of course, the stupidest thing you could do under the circumstances. I got up, I left the office, and I drove myself to the CVS store, and I stuck my arm in one of those, blood pressure machines, which probably don't work very well. But I had this sense that my blood pressure was really high, and indeed, it read very high. So then what did I do? I drove myself to, and it was really high, and I'd never had a problem with blood pressure before. So I did, again, a stupid thing. I drove myself to the ER of a hospital, and I got in line, and I walked up, and the guy in front of me was there in handcuffs with a cop, and he was being brought in on an emergency psychiatric hold. He hadn't committed a crime, but he was clearly having a crisis, and his family or whoever he was with had called 911, and the cops came, and they handcuffed him, and they brought him to the hospital. You imagine that, that's again, somebody who's going through the terrors of a psychiatric episode, and they get handcuffed. And I remember that the woman sitting there, the triage nurse, kind of looked at the cop, rolled her eyes, and said, "Bring him up to the 8th floor." And I'm thinking, oh, great, maybe I should turn around and leave. Is she going to treat me this way? And I walked up, I was wearing my jacket and tie, and looking like a middle-class white guy, I told her what my symptoms were, and she immediately, oh, well, please go in and sit down. And she then came and talked to me, and couldn't have been nicer. And within a half hour, I was in a, being treated, and I've been on blood pressure medication ever since, but my blood pressure is stable. But I was treated so differently than this guy was. He was treated like he was a criminal, even though he wasn't a criminal. He had a brain disorder, not a disorder of he didn't have a cardiovascular disorder or a pancreatic disorder. He had a brain disorder, and it was like she just didn't even want to deal with him. Budget cuts have certainly been part of it, however. We've trimmed, according to NASHBID again, the National Association of State Mental Health Program Directors, more than $3 billion in state general funds from our mental health systems since fiscal year 2009, which was when things started to really get bad with the budget crisis. That's just from the state general fund appropriations. That's not even taking into consideration Medicaid. Interestingly enough, until this year, we largely held Medicaid harmless because the stimulus package actually, as again, I think most of you know, infused some additional federal resources into Medicaid. But guess what? At the end of June this year, those additional resources expired. States are taking a huge hit this year in loss of federal Medicaid revenues. So now we got a double whammy in the mental health system. We're not only see cuts in general mental health funding, but we're going to see potentially, and this is going to not only impact on people with mental illnesses, on all Medicaid populations, potentially cuts to Medicaid, cuts in terms of what's covered, cuts in terms of who's eligible. We've seen a lot of states in the last 10, 15 years take progressive steps towards expanding the numbers of people they cover in Medicaid, moving towards that 100% of federal poverty level. Now, states like Arizona are stepping back and saying, if you're a single adult and you don't qualify for Medicaid through SSI, you're not eligible for Medicaid. Of course, you could say, well, if you're severely disabled, you qualify for SSI. It's not that simple. I think some of the most disenfranchised people with mental illnesses are not on Medicaid because they don't have the wherewithal to apply for Medicaid and keep reapplying for Medicaid and filling out the paperwork. All right, I really have to get off this negative thing here. We do reports on budget cuts. In fact, we have one coming out next week. I've been working pretty hard on it with my colleagues. And, actually, I'm hoping that the worst of this is over in terms of the magnitude of budget cuts. I'm worried about the Medicaid. 2014 can't come soon enough as far as I'm concerned. I know that, we've been very aware of the differing opinions that exist about the Affordable Care Act, but the Medicaid expansion, the people up to 133% of poverty, could be really huge. Could be probably a lot of people with mental illnesses who will be included in that population of people who are added to the Medicaid rolls. Now, as I'll tell you in a few minutes, there are still some concerns around that, but can't come soon enough, assuming the law survives, which I'll also talk about in a few minutes. Missouri, again, just to tell you very quickly, and I actually have made notes here for myself, which I've completely ignored, which I do every time I do a presentation. Maybe just making the notes themselves are helpful, I don't know. But Missouri has cut $60 million from its general mental health budget in the last 4 years. And now what's happening in Missouri, like we're seeing in a lot of other states, is that as states are faced with losing these additional federal Medicaid revenues, they're shifting their mental health dollars to the Medicaid populations. So the uninsured who don't have Medicaid are really out in the cold. That's true in Missouri, and it's true in a number of other states too. Something we really have to pay attention to. Okay, so fragmentation. Well, again, I really do want to get off this downer kick, but certainly, fragmentation is a problem, I think, in the healthcare system generally. It's certainly a problem in the mental health system. And when we talk about fragmentation, that's sort of a favored buzzword that's been used since the President's New Freedom Commission report came out in 2002. But what we're talking about is poor coordination between hospitals and the community, oftentimes different systems running those, different entities running those systems, different funding streams paying for those services, poor coordination between mental health and substance abuse. And again, I think probably many of you know the rates of co-occurring mental illness and substance abuse are extremely high. And people who have both disorders, who are duly diagnosed, need treatment, coordinated treatment for both, but oftentimes that coordinated treatment doesn't exist. Fragmentation between primary care and mental health care. Fragmentation between incarceration and community reentry. When people get arrested, they lose their Medicaid. And then when they come out, it might take them months to get their Medicaid back. And in the meantime, how are they going to get their medications? How are they going to get the services they need? And we're not even talking about housing and things like that. Fragmentation between treatment and supportive services. Because you know, mental illness, the nature of mental illnesses are that medical treatment is only a small part of the equation, obviously. We're talking about people who are among the poorest of the poor in this country, and the waiting list for subsidized housing, many of you are aware of the Section 8 program, some communities are 15 to 20 years long. And then fragmentation between, on the one hand, the quest for recovery, and on the other hand, the way our public entitlements work in this country. That really force people, in a way, to be dependent and penalize people for recovering and wanting to go back to work. Because when you go back to work, you risk the loss of benefits that you may never get the equivalent of, even if you're lucky enough to get private insurance. So these are all, you know, big problems. Some of these problems are much broader than just mental health. They apply to chronic illness in general. And in a few minutes, when I get to the happier part of the presentation, you know, I'll really give kudos to Missouri, because I think you, as much as any state, are trying to address these fragmentation issues through your emphasis on health homes in particular. Historically, we know that neither private insurance, Medicaid, or Medicaid have covered mental illness on par with other medical disorders. You know, give you just a couple examples. Historically, the copay for outpatient treatment for mental health treatment in Medicare has been 50%, as opposed to 20% for all other medical disorders. Historically, there's been a lifetime limit of 190 days in Medicare for inpatient psychiatric treatment. No such limits for any other medical conditions. Historically, private insurance companies have had lifetime limits, annual caps on benefits, limits on the numbers of days that they cover that are far more draconian for mental illness than they are for other medical illnesses. All of that's starting to change. And so, see, I'm starting to make this transition finally from this being mired in misery to giving you a little bit of a happier picture. I thought I was anyway. But I do want to talk about a few of these as well, because I think this is an important part of the equation. The reality that many people with mental illnesses live in extremely substandard living conditions. You know, we've been systematically closing hospitals, but people oftentimes end up in nursing homes, younger people with mental illnesses in nursing homes, in adult care homes, that some of which are not very well regulated and can be pretty scary places. You know, sort of flop houses in the worst part of the community, in the ghetto. Some people with mental illnesses, and this is getting now, I want to talk a little bit about why so many people with mental illnesses are reluctant to seek help. Because that is, for those of you who are mental health treatment providers, you know that can be very frustrating. Many people have had negative experiences with the treatment system. Again, getting back to what I was saying about the second-class status we accord people with mental illnesses. You know, thinking about that example I gave in the emergency room. Trauma, we've become more and more aware, is a big part of the experience of mental illness. It's not only, you know, when I get a little nervous in talking about trauma, because when I started at NAMI, there were a lot of folks who were still blaming mothers for schizophrenia. There was a term, the schizophrenogenic mother. We've moved away from that. But the fact is that people with mental illnesses, many can tell you about some extreme trauma that they've gone through in their lives. Maybe not necessarily family-based trauma, although there is family-based trauma in some cases, but trauma in their experiences of psychiatric treatment, particularly if they've been in state hospitals. As a lawyer, I've had occasion to read too many reports that have been put out by the Justice Department when they do investigations under the Civil Rights of Institutionalized Persons Act and investigations of state hospitals. And you read things about, like, high rates of physical and sexual assaults, staff trading, and again, none of this is directed at anybody in this room, staff trading contraband like drugs and cigarettes for sexual favors. And you read that stuff and you think to yourself, well, are these all that different from prisons? And I think it's gotten worse in a way because more and more our state hospitals have become forensic facilities. In some states, California, for example, 90% of all patients in California's state psychiatric hospitals are forensic. They're there either because they've been found not competent to stand trial, having been charged criminally, or have been found not guilty by reason of insanity. So they do become, the character of the people who are in these hospitals, the characteristics rather, maybe a bit of a more dangerous population, combined with staffing cuts and poorly trained staff, it's not a pretty picture. So if state hospitals are becoming less and less of an option for people, where do they go? Well, some people go in the community. Some people do very well in the community. Some people do much better in the community than they did when they were in hospitals. But there are some people who need long-term care. And so that's something that we have to think about. And then finally, this phenomenon of what's called an anosognosia, which is a sort of a neurological term, but what it basically means is lack of insight, denial of the need for treatment. And when people are symptomatic, it's not uncommon that they will deny that they're sick and that they need help. In fact, a guy named Javier Amador wrote a book called "I'm Not Sick, I Don't Need Help." And I think all of these factors probably contribute to people's reluctance to participate in treatment. If you want to start a food fight in the mental health world, you'll start talking about, well, what do we do if people refuse treatment? There's been a raging debate about whether civil commitment standards are too rigid, and that waiting until somebody is overtly dangerous before an intervention can occur is too long. Depending upon what side of the fence you sit on, you'll say yes or no. And it's an issue that sometimes divides consumers, mental health consumers and family members. Some of the more promising, there have been some promising innovations that have emerged, like psychiatric advance directives, the psychiatric equivalent of a living will, where people have an opportunity to indicate what their treatment preferences are and who they prefer to function as a surrogate decision maker, should they lose their capacity to make an informed decision. All of these things have to be explored, but these are all factors, I think, that contribute to poor treatment outcomes. So now, finally, beacons of hope. We've seen the passage of insurance parity laws in most states in this country, and very importantly, we had a federal parity law. We worked on that federal parity law since 1992 at NAMI, and it passed a couple of years ago. And what it basically means is that, at least for insurance plans that are covered under the requirements of that law, insurance plans have to basically treat coverage of mental health conditions in the same way they treat coverage of physical health conditions. So no longer can they, and that's true also for substance abuse disorders, by the way, no longer can they impose discriminatory copays or limits on days of coverage that they don't for other disorders. Healthcare reform includes in a number of its sections a real emphasis on mental health treatment. In fact, it's very gratifying to see in the various sections of the law. How many of you have read the law from front to back? Don't lie now. Notice I didn't raise my hand. I've read most of it. You've actually read the whole thing. Well, then you can tell us that there's a lot of talk in all the key sections of the bill. You see mental health at least talked about in the same context as physical health. Again, I think we're slowly moving to recognizing mental health as part of the overall healthcare paradigm in this country, and that's a good thing. And again, growing focus on more effective integration of care, and again, Missouri's been at the forefront of that. Commitment in some areas to improving overall health and wellness, addressing those early death rates and high rates of comorbidities. A growing emphasis on recovery. We never talked about recovery when I started out in this field. We talked about survival, but we didn't talk about recovery. But now we talk about recovery, the reality that people can live meaningful, dignified, contributing lives, that a diagnosis of a severe mental illness doesn't have to be a guarantee that the person is going to have a lifetime of misery. And maybe as important as anything, the emergence of people with mental illnesses themselves as leaders and providers of services. We were very slow to come to that. The substance abuse field obviously was way ahead of us on that. So let me skip over some of this. How am I doing on time? I lose track. Karen, 5 minutes. Gosh. And I thought I wasn't going to have enough time. I mean, I thought I was going to not have enough slides to cover it. So there are many aspects of the Affordable Care Act that I think are very, very exciting. I'm just going to mention a couple for people with mental illnesses. Obviously, we're going to have some real challenges in the implementation of the law. I think outreach to hard-to-reach populations is going to be one of the big challenges that I think all of us in this room who are concerned about reaching people who are disenfranchised and maybe don't have access to private insurance. That's going to be one of the biggest challenges that we have to get people enrolled in these plans. If you look at how this whole debate about health insurance exchanges and about the expanded Medicaid program is shaping up, you realize that just the procedural burdens of getting people enrolled and making decisions about whether people fit into the insurance exchange compartment or whether they fit into the expanded Medicaid compartment are going to be huge. And again, I'm here representing a population that has historically been particularly hard to reach and enroll. So I think those are going to be tremendous challenges. But having said that, I think there are going to be a number of people with mental illnesses who, if this law is actually implemented, and that's a big if, will have access to potentially to quality medical care and mental health care for the first time through insurance. Well, I'm a little worried about the insurance exchanges because I'm worried that the essential benefits that they cover are going to be defined pretty narrowly. That's certainly something we're working with our advocates in the states to prepare them to register meaningfully in these debates. Through expanded Medicaid programs, although it's not clear that the expanded Medicaid programs will have to cover the same level of benefits as traditional Medicaid programs do. That'll be an advocacy fight for groups like mine. I have more and more hope and optimism about the medical home option in Medicaid. And how many of you in here know that Missouri was the first state that was granted a waiver to develop a statewide medical home? It's a tremendous accomplishment, and it really speaks volumes for your state and for the spirit of cooperation that exists between your community health centers and your community mental health centers. And probably many of you in this room worked on that, right? And you have a long road ahead of you to make it work. I think you're going to face some significant challenges, but I also think a lot of states are going to be watching Missouri and watching this really tremendous experiment that you're embarking on. There are a number of other states that are working on applications as well and working on plans. None of them seem to be quite as far along on a statewide basis as you are. You know what? Karen last night at dinner asked me about what I thought would happen with the Supreme Court cases challenging the ACA, and I gave her a very stupid answer. I basically said, I don't know. And I really don't know. And I was going to even get into, I thought about it a little bit this morning, and I was thinking about the Commerce Clause and whether health care is commerce, and that's what it comes down to, whether health care regulates commerce in this country. If the Supreme Court decides that it does, then they'll uphold the law, and if they decide that it doesn't, they won't uphold the law. And your guess, given how polarized the Supreme Court is at this point, your guess is as good as mine, but my guess is it's going to be a 5-4 decision, and Justice Kennedy is going to be the deciding vote. So I'm going to skip over these two. I don't know how our speaker this morning, he had about 100 slides and he got through them in plenty of time. And here I am, So I have a couple slides about your Health Home Initiative, but I would wager that there are a number of people in this room who know more about that initiative than I do. I think that it is an opportunity to address many of the problems that I've been talking about today. The fragmentation of systems, the need for better coordination, the need for better integration of primary care, and mental health care, and substance abuse treatment. I wonder how social services are going to factor into the equation, because again, many of the fundamental services that people with serious mental illnesses need are social services. So you're really going to need to have at the table folks who are responsible for administering housing programs, folks who are responsible for administering employment programs. Because if people don't, and particularly, I keep thinking about housing, because I think housing is one of the real critical components of recovery. In fact, without decent housing, I think anything else you do is going to be very hard to succeed. There's been I think, a very promising approach to housing that has emerged around the country in the last 5 to 10 years called supportive housing, called Housing First. Are you familiar with, anybody in this room familiar with Housing First? The whole premise is that first you get the person decent housing, and then you can really start to focus and hopefully get the person engaged in participating in psychiatric treatment, participating in substance abuse treatment, and taking the steps that they need to do to help themselves. But if the person is living in substandard conditions or is homeless, it's really hard to get them engaged in these other components. So I really think that that's going to have to be a part of the whole health home initiative in this country. And I certainly, in reading through the plan, saw that referrals for social services is part of it. But money for social services is going to be so critically important. If a health home initiative is going to really work, there have to be some funds for housing and these other services specifically targeted for those populations. I'm convinced of it. I'm convinced that otherwise it's not going to work. But I know it's going to work in this state. Let me finish off, because and I'm sorry for skipping over all these slides. They'll probably be posted on the website, by just talking about some of the critical challenges that will be faced going forward. I really do feel a sense of optimism. I think we've passed some laws that help people, like parity, like the Affordable Care Act. I think that we have developed some partnerships with some unfamiliar partners, some unexpected partners who are really helpful to us. I do, as I said, a lot of work with law enforcement, with criminal justice. When there are budget hearings held in states now, you get these sheriffs with handlebar mustaches to get up there and testify about that it's a bad idea to cut mental health funding. It is so powerful. It's much more powerful than a bleeding heart liberal like me getting up there and saying it. And we're seeing that. We have some of our best partnerships are with law enforcement and other elements of the criminal justice system. We're seeing an emerging respect for people with mental illnesses. I would like to think in 10 years, maybe 5 years, maybe even today, that guy who was in line ahead of me isn't going to be treated the way he was that day. More of an emphasis on treating the whole person. More of some work by very creative, smart people to think about how to achieve smooth transitions between the systems that are so fundamental to recovery for people. The Health Homes Initiative. I keep getting back to that. I hope every state follows your lead, and I hope every state is as successful as I know you're going to be. Notwithstanding all the tremendous challenges that all of us face, I mean, just listening today, listening to all the problems with workforce, listening to some of the entrenched ways that the healthcare system still does business and the resistance to positive change. You take that and multiply it by 10 and you have the mental health system. But I still think we're making progress as a country. Even though many of the people in this country don't seem to understand that it's progress. I think we are making progress. I think that probably what's going to be the deciding factor, this ultimate decider, is that our health care costs in this country and our mental health care costs in this country are bleeding us dry. I mean, they're one of the biggest factors that are contributing to our economic crisis in this country. And that's probably going to be the factor that ultimately gets the politicians and the policymakers and the various people who are involved in shaping the healthcare system to maybe sit down and really create a system that works. You're probably now sitting there thinking, well, this guy went from being Dr. Doom and Gloom to being totally naively unrealistic about how bright the future looks. But I know for me, having been at this as long as I have, I got to think that way. That's the only thing that keeps me going every day. So with that, let me stop and thank you for your attention during this tough after lunch slot. And I didn't see too many people fall asleep. Of course, I was only looking at one side of the room, I'm now realizing. I apologize to those of you on this side of the room who I didn't look at, but you guys probably got a good nap. So anyway, so let me open it up for questions. Have I been so comprehensive in my presentation that I've solved all the problems? Yes, sir.
Yes, I'd like to ask, I work as an advocate, primarily people with physical disabilities, and we have been very fortunate with our lawmakers, one of them sitting here as a matter of fact. And
right next to you. Right?
Yeah. As far as our services and so on, we've been very fortunate, but every year at the Capitol I see this happen. We'll get basically either good news or at least news we can deal with. And every year it's the same story. Mental health, whack. And I want to ask, you know, there are two factors that I'm curious about. One of them is the source of funding, because I think a lot of mental health comes from the general fund, and so it's more vulnerable than, say, something that's federally matched. And the second thing is a little more probably controversial, and I actually did have a lawmaker say to me at one point, those people are all drug addicts and drunks, and there's a stigma there, and I think we all know that. To what degree do both of those affect the funding that you're getting? Because I know you guys get whacked just incredibly compared to other services.
Both great questions. Well, let me talk about the financing first. About between 50 and 60%, I haven't seen the latest data, because Medicaid data always lags about 5 years behind where we really are today, and that's one of our problems, I think. But between 50 and 60% of all public sector mental health services are funded through Medicaid. And you know, Medicaid has been a huge driver, a cost driver in the mental health field. So again, all the incentives, it's something I was trying to say in my presentation. I don't think I said it very well. All the incentives have been to put most emphasis on Medicaid populations, because for every dollar a state spends on Medicaid, as you know, they can draw down $2 or more from the federal government. But you know, I think something like 40% at this point in time comes out of state general funds. So yes, when a legislature or a governor is looking at you know, a significant budget deficit, and unlike the federal government, most states are constitutionally required to balance their budgets. There's only certain areas that they can cut, right? They can cut education, they can cut corrections, they can cut mental health, and maybe transportation. Well, and so, you know, when it comes to that competition, developmental disabilities as well. So when it comes to that competition, mental health is very vulnerable. And yeah, we have taken whacks in many states, although not all states. And what has been the somewhat of the saving grace up to now has been this, you know, this 18 months of enhanced federal matching in Medicaid. And when that came to an end in June of this year, states were faced with a loss of federal Medicaid revenues of $15 billion or more. And I think we have yet to realize the full consequences of that. So, but back to your point, yes, you know, mental health is always a very vulnerable area in state general funding, because it's one of the, there's not that many areas that states can look at. And cutting schools is fraught with, obviously, political peril, and I would never advocate for that. That's also a dilemma for advocates, because I personally think we do better when we work together. I don't think any of us are strong enough to work by ourselves. But during desperate times like these, there's a tendency to pit advocacy groups against each other. And so you have developmental disabilities and mental health fighting over an increasingly shrinking slice of the pie. Your second question concerns really stigma, right? And is that a factor? And I think it definitely is. I think that you know, despite the fact that organizations like mine and many others, we've worked very hard on public education, on stigma reduction over the years, and I think there's been some progress made. I certainly think that there are many in society that don't understand mental illnesses well at all, and sometimes it shocks me when I get together socially with some of my friends who've known me for years and have known what I do for years, and they say things about mental illness that just shock me, you know, and some of them even have had people with mental illnesses in their families. Every so often we get reminders even from legislators. The chair of the Senate Appropriations Committee for Health and Human Services in Florida was quoted a couple weeks ago as saying that, in his opinion, mental illnesses are basically character weaknesses, and that people basically need to pull themselves up by their bootstraps, and that we've been spending all this money on mental health over the years. By the way, Florida is second to last in the country on per capita spending on mental health, and it's not that poor a state. Compared to Florida, Missouri seems quite generous, although you're below the average in per capita spending too. But he actually says that he's going to propose a zeroing out of state general funding for mental health. I don't think he's going to succeed. One of the things that happens when these types of draconian challenges occur is the advocacy groups do tend to rally together, and I think that'll happen in Florida. But yeah, I think if people understood better about mental illness better, and if they viewed people with mental illnesses more compassionately, I think we'd have a much better chance of getting our fair share of the resources. Part of it is also, when does the public hear about mental illness? Do they hear, I started off by talking about these sort of uplifting, hopeful articles about heroic people that have overcome the barriers of mental illness in the New York Times. But the people we need to reach, first of all, by and large, don't read the New York Times. And even if they do, when do people hear about mental illness? After Arizona, when there's a terrible shooting, right? So they hear about Jared Lochner, and they see a picture of this guy who scares the wits out of everybody. And that's their image of mental illness. And I don't hear a lot of people saying, poor Jared Lochner, if only someone had intervened and gotten him help, it probably never would have happened. The people who died would be alive today. Congresswoman Giffords wouldn't be struggling heroically to overcome her severe brain injuries. You don't hear people talking about that. You hear people talking about this monster. And so, I don't know. I think we just have to keep working at it. I saw a hand raised in the back.
Well, thank you. Well, thank you. I had a question. I'm a primary care physician, and I couldn't agree more with you when you when you brought to light some of the aspects about mental illness. I do agree that it's treated as a big blob, a dark blob, and people lose credibility. They almost lose their autonomy and the right to be treated courteously and be provided the highest quality of care if they have a component of depression or any other kind of mental illness. My question to you is, coming out of this stigmata and the way we treat people when they mention depression or anxiety, etc., there's a lot of apprehension in the patient population to discuss with their physicians regarding these illnesses, because it goes into the electronic medical record.
Yeah.
And many times when they're applying for disability or insurance, they have to sign forms that allow them to release medical records. And they don't want anything in those medical records that can be used by these insurance or disability, etc. Programs to discredit them or give them a higher rate, or in any way that would disadvantage them. And I would like to think that mental illness, few of them are organic, hardcore organic illnesses, but some of them are also situational and stress related. And we cannot discredit our patients at the same level and call them disabled to a certain extent, the way these insurance or the way it's perceived, I may say. So what is the movement, or what are patient rights in this regard? When are they requested, or when do they really need to disclose? Because there is a self-voluntary component also that they have to reveal if they have ever been counseled or seeked attention for their mental illness, which again is just emotional, It's such a big cloud. So when do they differentiate that I'm going to reveal this? This is my private space. Nobody needs to know this. Versus they say that, yes, this is reportable. I am impaired because of this. Who makes that call? Who advocates for them to be able to make these decisions?
Well, I actually think this is a problem. You're raising a very important problem, and it's a problem as much of perception and what the person with a mental illness perceives as what really happens. And again, I'm not talking about that in a symptomatic as it being a symptom. But I think certainly people with mental illnesses have legitimate reasons for fearing the inappropriate disclosure of their illnesses. And by the way, I'm going to digress for a second. We really don't know. It's funny. When I started at NAMI, our mantra and many of the scientists studying mental illness said it's clear schizophrenia, bipolar disorder, major depression, et cetera, are biological. They're rooted in the complex biochemistry of the brain. There's certainly a lot of evidence that that's true, but there's also lots of evidence that environmental factors impact significantly on both the initial onset of these illnesses, the severity and the impact of these illnesses. And the course of these illnesses. So there is this complex interplay between biology and environment, particularly even with people with serious mental illnesses. And then, of course, you do have a lot of people with mental health issues that relate to the stresses of life. There's this fear that if information about these illnesses are disclosed, that it's going to have a terrible impact on your life, ranging from not being able to get a job, to not being able to get housing, to not being able to have good social relationships, particularly in small towns where, as we all know, word of mouth travels fast. So there are, however, as you also all know, a variety of laws that protect people, theoretically, from discrimination on the basis of disability, and also laws that to some extent or another, create parameters with regard to privacy of medical information, like HIPAA. And I think, actually, that HIPAA is about the most misunderstood law ever written in this country. That there's a real disconnect between what HIPAA requires and what people perceive HIPAA as requiring. But the fact of the matter is I would say in the big picture, and this is going to be maybe shocking to you a little bit, that I don't think it would be good. I think the fact that we have always viewed mental illness differently, as more protective of privacy than other medical conditions, is one of many factors that has contributed to the second-class status of mental illness and the reality that mental health treatment has oftentimes not been part of the overall healthcare system. Whether we like it or not, we're moving into an era now of health information technology and electronic health records. And we need to certainly, and that was actually one of my slides that I didn't get to, we certainly need to figure out a way, it's not going to be easy, but we need to figure out a way to achieve a happy balance between moving forward and including mental health in electronic health records and maintaining proper protections for privacy. The fact of the matter is that it's not in the best interests of somebody with schizophrenia to have his or her information not available to other people who are involved in his or her treatment. Otherwise you can't assess things like the impact, the interactions of different medications. You really can't develop a good comprehensive treatment plan. What I think we do need to do is, A, provide people with assurances that their information is not going to be inappropriately disclosed, that we certainly need to do everything we can to enforce the laws that exist in this country, including the Americans with Disabilities Act, which has strong confidentiality provisions in it. But I, for one, would argue, I mean, when HIPAA was being debated, I'm being a little all over the map with this answer. When HIPAA was being discussed, there were some in the mental health field who said mental health there should be much stricter standards for protecting privacy in mental health records than other medical records. And in fact, there is a provision in HIPAA that provides very, very strong protections for psychotherapy notes, for the intimate details of the psychotherapeutic relationship. I'm not talking now about diagnosis, treatment plan, medications, et cetera. I'm talking about, some of the more detailed interactions that occur between a therapist and a patient. But overall, we did not support stronger protections for mental health because in the long run, if our goal is to integrate mental health into overall health care and to achieve better coordination of care, I don't think it's in our best interest to say, but when it comes to mental health, it shouldn't be included in an electronic health record. Did I even begin to start to answer your question? Not really, huh? Well, why don't maybe we could talk afterwards and we could try to explore this a little bit better. It's not easy. Other questions or comments? Yes.
And this needs to be our last question.
Yeah, that's because my answers are so long. I'm not giving people time.
I understand what she's saying. One of the things that my law firm does is we practice disability law. Mm-hmm. And I have got clients that are terrified on the disability, Social Security disability form. It says, do you have physical conditions? Do you have mental conditions? And I have a terrible time getting clients with stage 3 cancer admitting that they're depressed. Right. Or they're anxious. Right. That's because of a couple of reasons. Some of them have long-term disability carriers right. who will actually contract their coverage yes. if there's a disclosure yes. of a mental illness. Yes. They need their health insurance or their disability insurance. When you got stage 3 cancer, stage 2 cancer, you're not going to disclose anything that would make an insurance cover look at you differently. And even I just think about the medical records that I read. I spend my days entrenched with medical records, and I read something where somebody's complaining, and I had a client tell me yesterday that he's got stage 4 lymphomic cancer now. They thought his stomach ache was, he has a history of depression and anxiety. That's what they saw.
Right.
And maybe he thinks if he hadn't disclosed that, and even Social Security does it. Social Security does that. Doctors do that, primary specialists. Yeah. Once they find out you've got this other history, well, then maybe we don't need that other MRI. Yeah. Maybe that CAT scan.
That's true.
Well, and then so you're afraid for very practical reasons that your insurance coverer is going to retract coverage. You're afraid of the care you're going to get because once that's in that history and people are going over it, then complaints are looked at with suspicion. And I have a lot of clients, some very sick clients that could have been helped sooner, but I just had a gentleman who his stomach ache last year maybe could have been prevented from the stage 4 that's this year because he also had some mental history that was just poo-pooed. Yeah. And so I
hear you.
I think that the increased security or restriction of mental health issues is justified given the very real realities of restricted access to general care. If you're a cancer client, I would advise my clients that if you really think that that's going to be issue and your concerns aren't going to be taken seriously, I would advise my client then, unless you think that's disabling you, let's keep that off that form.
Well, unless it's disabling you. But in the short run, I would agree with you, but in the long run, it's not going to lead to progress. Suzanne Vogel-Zabilia, who was our former board president, who's a psychiatrist and has bipolar disorder, tells this story. I mean, she's a brilliant physician. And she tells this story about a time she was having she had a ruptured appendix, basically. And she was in an emergency room. And when they heard she had bipolar disorder, they started discounting her symptoms and started, thinking, well, maybe we should first refer her for a psychiatric evaluation. So I hear exactly, and then she finally said, look, you idiot, here's my lipid levels, here's my, I don't even know what the test is for a ruptured appendix, but she knew exactly what the clinical indicators were, and she said, here are my clinical indicators, where did you go to medical school? I know when I went to medical school, I know exactly what that meant. I did a rotation here, et cetera, and they finally listened to her, and indeed, her appendix was about to rupture, and they did an emergency appendectomy. So I know exactly what you're talking about, and I think that look, stigma, we talked earlier about stigma. Stigma exists within the medical profession too, and among everybody involved in healthcare treatment, and that's really too bad, and we need to work really hard to overcome that. I also know what you mean about long-term disability policies. Most long-term disability policies in this country cover, if you have a mental nervous condition, you get benefits for only 2 years, right? I've been involved in some lawsuits challenging that under the ADA. We didn't win any of them. So I know exactly what you're talking about, but all I'm trying to say is that in the long run, we have to get to a point where it's safe to include information about mental illness in a medical record. Otherwise, we're not going to ever get to the point where we really achieve true parity in the coverage of mental illnesses with physical disorders. And I wish I could stand here and chart out how we're going to get to that point to you, but I can't. I just think we have to keep working at it. And public education, work on stigma reduction, et cetera, are really keys to that. And one thing we can all do in this room is we can work on overcoming stigma within our own communities, within our own professional communities, because that to me is, I mean, how are we going to get, the average citizen in this country to start viewing mental illnesses a little bit more compassionately and a little bit more accurately if we can't get our medical practitioners to do so? Boy, I just ended on a down note again, didn't I? Thanks.